and I hereby request you to send the cases before 1st January. So, the first case for today's discussion is SCA from Department of Neurology, presented by V. Manashwi and moderator Dr. K. Vamsikrishnan.
From gene to phenotype, a case of Mars syndrome, rare HSP. Presenting complaints, 45-year-old woman, a homemaker, presented to OPD with chief complaints of slurring of speech since 6 years, unsteadiness in gait since 6 years, aggravated since 3 months. History of present illness. Patient was in her usual state of health 6 years back, after which she complained of slurring of speech, which was insidious in onset, gradually progressive till date. She is able to understand but unable to speak with clarity. Slurring is not associated with any diurnal variation, dysphagia or facial weakness. Complained of imbalance while walking, which was insidious in onset, gradually progressive. Initially, she was able to walk without support. It had progressed to a state where she was able to walk only with support of wall in a period of 1 year. Imbalance got worsened over the past 3 months such that patient was unable to stand for a long time. She had difficulty in navigating feet into the chappals, able to hold chappals initially, but she noticed slippage of them since 3 months. She is able to mix food, but unable to take it into mouth since 3 months. She is able to comb her hair normally. No history of involuntary movements, giddiness, lightheadedness, nausea, vomitings. No history of abnormal or loss of smell sensation, double or blurring of vision, loss of color vision. No history of problem in chewing. No history of deviation of mouth or drooling of saliva. No history of hearing abnormalities. No history of regurgitation of food or hoarseness of voice. No history of difficulty in swallowing both solids and liquids. No history of SOB, cough or wheeze. No history of chest pain, palpitations. No history of abdominal pain or loose stools. No history of decreased or increased frequency of micturition or burning micturition. Past history, she is not a known case of hypertension, diabetes, CAD, CVD, PTB, bronchial asthma, epilepsy, CKD or CLD. History of tubectomy done 22 years back, no history of blood transfusions. Personal history, she takes mixed diet, normal sleep and appetite, normal bowel and bladder habits, no known food, drug or environmental allergies. Family history, she is born to a non-consanguineous marriage. Her father expired due to throat cancer in 2018 and her mother due to lung cancer in 2016. There are 5 sisters. Our 4th sister has a history of dysphagia, cognitive impairment, bowel and bladder habits. 2nd sister is the affected one. General examination. Patient is conscious, coherent, well-oriented to time-place person. Her BMI is 24.4 kg per meter square, which comes under normal weight. GCS is E4, V5, M6, 15 by 15. Pallor present, icterus cyanosis clubbing, lymphadenopathy, pedal edema absent. Vitals at the time of presentation. BP recorded in supine position is 120 by 70 mm of Hg, and in sitting position it is 110 by 70 mm of Hg. Pulse rate is 72 beats per minute. Respiratory rate is 14 cycles per minute. Temperature is normal. Saturation is 99% on room air. GRBS is 102 mg per dl. CNS exam, systemic examination, CNS examination. She is right-handed. She studied up to intermediate first year. Higher mental functions are intact. Patient is conscious, coherent, oriented to time, place and person. Recent, immediate, remote memory intact. No apraxia, hemi-neglect, hallucinations or delusions. Her MMSC is recorded. It is 29 by 30. Her speech is slow, strained speech. Repetition is intact. Reading and writing are intact. Naming objects is normal. ఎక్కడి నుంచి మీరు సిగ్నల్ ఏం చదువుకున్నారు? ఇంటర్ ఫస్ట్ ఇయర్. Cranial nerve examination. Olfactory nerve normal. 3, 4, 6 cranial nerves are normal. Trigeminal fifth nerve is normal. 7, there is no facial asymmetry. 8, 9, 10, 11, 12 are normal. Motor system examination, attitude is normal. Bulk is bilaterally symmetrical. Tone spasticity noted in all the 4 limbs. Power, right upper limb power is 4 by 5. Lower limb is 4 minus by 5. Left upper limb is 4 by 5. Lower limb is 4 minus by 5. Reflexes. Superficial reflexes, plantar, bilateral extensors, corneal, conjunctival, abdominal reflexes are present. Deep reflexes, all the upper limb and lower limb reflexes are exaggerated or brisk. Sensory system examination is normal, Romberg's test is negative. Cerebellar examination, upper limb, finger nose test, there is pass pointing on both sides. There is no rebound phenomenon. Lower limb, she is unable to do heel hip test. Pendular knee jerk is absent. She was unable to do tandem walking. Her gait is narrow gait with adduction of thighs, legs crossing each other, indicating spastic gait. Systemic examination, CVS, S1, S2 heard, no murmurs. RS, bilateral normal vesicular breath sounds heard and there are no added sounds. GIT, vowel sounds heard. Provisional diagnosis, chronic progressive cerebellar ataxia with involvement of pyramidal tracts. It can be spinocerebellar ataxia or hereditary spastic paraplegia. ECG, this is normal standardized ECG, normal standardized valid ECG showing normal sinus rhythm. Chest X-ray.
This is a frontal chest radiograph. Patient is in rotation. Cardiac shadow appears within normal limits. Bilateral lung fields appear clear. Both domes of diaphragm well outlined. Both costophrenic angles are free. Normal chest rate.
2D echo is normal. Ultrasound in abdomen and pelvis shows no abnormality. MRI.
Sir, intubated axial images of MRI brain showing diffuse cerebral atrophy and also subtle bilateral periventricular hyperintensity suggestive of small vessel ischemic disease. These are intubated axial sections of MRI brain showing diffuse cerebral atrophy with subtle bilateral periventricular hyperintensities suggestive of small vessel ischemic disease.
MRI brain report. Diffuse age disproportionate cerebral atrophy with Fazekas grade 1 small vessel ischemic disease. MRI spine.
These are intubated axial sections of MRI spine at the level of C5, C6 and C6, C7 levels, showing presence of Perineural cysts on both sides at C5, C6 level and on right side at the C6, C7 level. These are the detubated sagittal images and also FFP axial sections at the level of C4, C5 level, showing posterior costified complex causing antethecal sac indentation and also parietal mild neural foramina narrowing, that's left greater than right.
Do you find any card thinning in the dorsal section, retrospectively based on the case? You think it's normal or anything in the dorsal card?
Normal.
At this age of 45 years, do you think that card, did you compare with the normal card? Because she's having a spastic quadriparesis. We are thinking like HSP. In HSP, like we expect to have the cervical card and dorsal card.
CBP is showing moderate anemia with normal serum electrolytes RFTs. Vials are negative. LFTs and CUV is normal. We suspected SCA, that is spinocerebellar ataxia, and we have sent for whole genome sequencing, which revealed a
Whole
mutation.
exome sequence, not genome.
Whole exon sequencing, which showed a mutation in gene SPG21. Fundus examination, bilateral eyes normal.
What do you expect in the fundus if it is hereditary spastic paraparesis? Because routinely fundus not it can aid in diagnosis.
Retinitis pigmentosa.
Can have an associated optic problem of optical.
Treatment given. She was given multivitamins and iron folic acid supplements. Final diagnosis: Mars syndrome. It is autosomal recessive variant of hereditary spastic paraplegia involving gene SPG21.
Only genetic diagnosis, genetic testing diagnosis. Based on the history, we thought of initially like scar its variant. So to confirm that, because there is a family history, doubtful family history of like an autosomal recessive nature, we sent the whole exome sequencing. In that, we find out this rare cause of HSP.
SPG21 means
Spastic paraplegia, sir.
Gene.
Spastic paraplegic gene.
Yes.
Therefore, there are 21. Have you at least verified the quantum of the gene table in Harrison? Reference to this?
Yes.
There are 89 genes.
Up to 90
Yes.
SPG variants.
What's your ultimate learning curve with this? As a president, it makes you to reinvent your knowledge of physiology. How much is displaced and different? Probably future, but now at present we know God is the country. How much we can offer is left to the future generations. Until the gene is identified much earlier, not effective because at this stage no gene therapy can be given after decade with the amount of it. But how can you make her living, walking a little longer?
Physiotherapies.
Orthopedics can do hereditary spastic paraparesis, certain types of anatomies, so that they don't cut into one to the other, such like they will have the adductor component of adduction is more spastic, that will be relieved by good old days, so that they don't fall while walking. An adduction like scissors, they fall forward as age advances. Therefore, they do give a release component of error and they can walk little. Ultimately, they will suffer very difficulty. Why stammering is there? Why speech is a problem? That means upper limbs are spastic. Therefore, the spasticity is gone up.
Oropharyngeal musculature is spastic.
What are the comments from your side?
Sir, this is when in literature this is when very rare case, sir. The thing is, sir, day by day these genetic diseases are in the rise. Previously, we used to treat like an HSP, complicated HSP.
Technology to evaluate. In good olden days, all hereditary spastic paraplesias and spinocerebellar grouped in one big chunk: ataxic, non-ataxic, paraparesis, spastic.
Ataxic, spastic, or ataxic plus spastic. Sir,
That very groups.
HSP means when pure HSP or complicated. Previously, when we used to treat like when complicated HSP or scar variants before genetic diagnosis, now it's like an era of genetic diagnosis. When we are labeling different genes day by day. Previously, when you used to read the genes are very less. Now it's up to 90. The number keep on increasing. So it's only for diagnosis purpose, but coming to the prognosis, it's very difficult to assess because genotypic presentation is different from phenotypic. All genes may have the same phenotype.
That's a wonderful statement. A genotypic expression is not the same phenotypically because the same gene is not expressed quantitatively similar, but maybe qualitatively component and vice versa. That makes all the variations of any neurological genetic disorder, including our PD, Parkinson's. This makes us to understand the function of the brain genetically more and where it can stand abnormally. These are all conflict less than 0.01%. Therefore, we must praise Almighty, who is never is abnormal in its balance of 99 precision 9. Otherwise, human race would have neurological, cardiological, everything. This is only 0.01. That is the beauty of precision of genetics, in spite of its accumulated idiocy.
Para Pashyanti Madhyama Vaikari. Para means the energy or external source or consciousness. Pashyanti means thought process. Then Madhyama means medium, that local cord, lungs, teeth, all those things. Vaikari means expression. See, if all the three were there, some people will not be able to express. So there's Vaikari. So all four are important.
A wonderful statement. Yes. Anatomically, neurologically made it out. Aphasic disorders, dysarthric disorders, euphoric disorders, and that is cognitive impairment and expressive disorders language. That is the beauty of the ancient scripture of that sloka.
Dermatology resident. I am presenting a series of 3 cases about gluten-induced bullous pemphigoid. My moderator is Dr. Shweta Chaudhary ma'am. Introduction. Bullous pemphigoid is an acquired autoimmune subepidermal blistering disorder predominantly affecting elderly more than 60 years individuals. Affected patients have autoantibodies against BP180 protein and BP230 protein, which are components of hemidesmosomes and basal keratinocytes. On drug-induced BP has been increasingly recognized with penicillin, furosemide, salicylates, dipeptidyl peptidase 4 inhibitors like gliptins, etc. We are presenting 3 gluten-induced bullous pemphigoid cases, highlighting its importance. Case 1, chief complaint, a 49-year-old woman presented with multiple fluid-filled lesions all over the body since 2 months. History of present illness. Patient was apparently normal 2 months ago when she noticed multiple fluid-filled lesions initially on thighs, gradually progressed to involve neck, abdomen and limbs, associated with itching, burning sensation. Lesions spontaneously ruptured to form erosions in 3 days, which are healing with pigmentation. No history of any oral lesions, no history of trauma, fever, difficulty in swallowing, joint pains and photosensitivity. On past history, no similar complaints in the past. Known case of diabetes mellitus on tablet glimepiride and tablet tinagliptin since 6 months. Type hypertensive on tablet metoprolol and telmisartan. Not a known case of TB, CAD and CD. Personal history normal, family history insignificant, general examination normal, systemic examination normal. On mucocutaneous examination, multiple vesicles in bullae of sizes varying 1 into 1 to 4 into 3 centimeters present over neck, chest, abdomen, upper and lower limbs. Bullae were tense in nature, which are containing clear fluid over erythematous to normal skin. Nikolsky sign is negative, bulla's PET sign negative. This is clinical image of bulla. These are clinical image of vesicles and bullae. Few erosions, post-inflammatory hyperpigmentation are prominent. Oral cavity, palm soles and scalp genitalia were normal. Provisional diagnosis, bullous pemphigoid. Differential diagnosis, linear IgA dermatosis, pemphigus vulgaris. Based on these clinical images, histopathological examination with subepidermal blister and direct fluorescence showing deposits of IgG and C3 and temporal association with drug stoppage and clinical improvement, we came with the bullous pemphigoid diagnosis. On treatment, since gliptins are significantly associated with BP, gliptins were stopped and patient was started on systemic corticosteroids, to which she showed a good response. During her stay in hospital, we gave a rechallenge of half the dose of gliptin because of uncontrolled sugars. A single half dose had led to rapid flare of lesions with intense itching, confirming the diagnosis of gluten-induced BP. Subsequently, drug was withdrawn and the patient was started on systemic steroids and good clinical response was seen. Patient now presently under remission since 8 months. Case 2. Chief complaint. A 79-year-old bedridden woman.
You must project the photograph of the same area after 8 months.
A 79-year-old bedridden woman presented with multiple fluid-filled lesions over neck, ears, upper and lower limbs since 10 days. History of present illness. Patient was apparently normal 10 days ago. Later, she developed itchy fluid-free lesions, initially over right great toe. Later, progressive to neck, ears, and upper limbs. Lesions were insidious in onset, spontaneously rupturing, leaving behind erosions in 3 to 4 days, and healing with crust. No history of oral lesions, no history of trauma, fever, difficulty in swallowing, joint pains, and photosensitivity. No history of new drug intake prior to onset of lesions. On past history, no similar complaints in the past. Known case of diabetes, illness on tablet linagliptin since 8 months. Known case of chronic anemia with regular blood transfusion once in 3 months. On hypertension, hypothyroid, and psychiatric illness present, and on regular medications. Known case of cholelithiasis, bilateral renal parenchymal and cortical cyst, large hiatus hernia, multiple GE junction ulcers, multiple ileal colonic diverticulosis, colon angiopexis. Not a known case of TB and CTB. Personal history normal, family history insignificant, general examination normal, systemic examination normal. Mucocutaneous examination. Multiple vesicles and bullae of sizes varying from 0.5 to 0.5 to 3 into 3 cm, mounted discretely over neck, both upper limbs, right thigh. Bullae were tense in nature, containing clear fluid over erythematous to hyperpigmented background. Mikulski sign was negative and bulla signs are negative. The clinical image of vesicles and bullae over the forearm. These are the vesicles and bullae erosions over the few erosions not extending beyond the margins noted over bilateral forearms, crusting noted over few erosions. Oral cavity, palms and soles, scalp and genitalia are normal. And differential diagnosis of bullous pemphigoid and pemphigus vulgaris. These are the investigations. Zanxmere showed eosinophils and neutrophils. Skin biopsy.
This is a focused photomicrograph of a HND stain section. This is a focused photomicrograph of a HND section in low power showing skin lined by keratinized stratified squamous epithelium. And in the high power, we can appreciate good number of eosinophils infiltrating the subepidermal junction, and few other occasional polymorphs and lymphocytes infiltrating into the upper dermis. And this is the direct immunofluorescence showing IgG deposits in the basement membrane zone of the epidermis in the perilesional area, features consistent with bullous pemphigoid.
Based on clinical images, histopathology findings, and DI findings, we come to diagnosis of bullous pemphigoid. Given the general condition comorbidities, we discussed with physician, started low dose steroids, and linagliptin was withdrawn. Patient responded very well on withdrawal of the drug, low dose steroids without immunosuppressants, thus confirming the diagnosis of gliptin-induced bullous pemphigoid. Presently, patient under follow-up with complete resolution of lesions on maintenance with tablet omnocortil 10 mg since 2 months. Case 3. Chief complaints. A 40-year-old man presented with few fluid-free lesions over upper and lower limbs since 2 weeks. History of present illness. Patient was apparently normal 2 weeks ago when he developed itchy fluid-free lesions over left, upper and lower limbs. Lesions were progressively increasing in nature. No history of previous trauma prior to onset of lesions. On past history, no similar complaints in the past. Known case of diabetes mellitus and was on tablet glimepiride since 4 years. Recently changed to tablet vildagliptin for 2 weeks. Not a known case of hypertension, TB, and CAD and CB. Personal history normal. Family history insignificant. General examination normal. Systemic examination normal. On mucocutaneous examination, tense bullae of sizes varying from 1 into 1 to 2 into 3 centimeters. These were noted over left forearm, left lateral aspect of lower limb with knee and dorsum of foot. Bullae were tense in nature with clear fluid over normal base. Nikolsky sign negative, bulla split sign negative. These are the clinical images of these bullae over left forearm, knee and dorsum of foot. On differential diagnosis, bullous fixed drug eruption, bullous pemphigoid. Investigations, skin biopsy.
This is a focused photomicrograph of a HND stain section in low power showing skin lined by keratinized stratified squamous epithelium. And here we can also appreciate few perivascular information. Here the subepidermal with few inflammatory cells, predominantly of eosinophils, few scattered polymorphs and other lymphocytes are also noted. This is the direct immunofluorescence showing linear and homogeneous deposition of IgG in the subepidermal region of the basement membrane of the perilesional area. Features are consistent with bullous.
Given the younger age, limited number of lesions with history of 2 weeks of gliptin usage, we have completed diagnosis of gliptin-induced bullous pemphigoid. Treatment: patient was started on short course systemic steroids with withdrawal of the drug. Discussion. Bullous pemphigoid is a disease of elderly characterized by 10 series of pseudosanguineous blisters with histopathology showing subepidermal bulla and eosinophilic rich infiltrates. On DIF, it reveals linear reposition of IgG and C3 complement at dermoepidermal junction, periregional skin. Its RBC technique shows roof pattern. These DPP4 inhibitors are gaining increasingly popularity recently due to its unique mechanism and very little probability of causing hypoglycemia, making them more preferred among physicians and patients. The long-term use of glutines has been associated with development of drug-induced BP. Drugs can trigger bullous pemphigoid in genetically susceptible individuals by altering immune responses or modifying the basement membrane antigens. Or long-term inactivation of the DPP4 by DPP4 inhibitors may potentially lead to breakage of immunotolerance for basement membrane antigen. Also enhances activity of monoinflammatory chemokines like CCL11 or eotaxin, recruitment of eosinophils with blister formation. Spontaneous BP has a typical inflammatory phenotype, whereas typical gluten-induced BP occurs at younger age with both inflammatory and non-inflammatory type. The latency between the start of treatment to onset of BP symptoms varies widely from 8 days to 6.5 years. These DPP4 inhibitors are associated with an approximately 3-fold increase in risk of bullous pemphigoid with vildagliptin followed by linagliptin, most strongly implicated in most studies. Arterial-like, prurigo-like, eczematous atypical variants, which are seen in 20% of classical BP cases, have not been reported in drug-induced bullous pemphigoid. Classical BP often requires high-dose systemic steroids with prolonged treatment, whereas gluten-induced BP improves after drug withdrawal and usually responds to topical or low-dose steroids with a better prognosis. However, disease process can continue even after withdrawal of the drug. When diabetic patients on glutines came with bullous lesions, have to consider about this entity. Thank you.
I'm here to share the experience with negative pressure wound therapy as a team work from the Unit 5 of Department of General Surgery headed by Dr. V. Mohan Rao. This presentation is not just a technique but also a shift in the wound care philosophy. Delayed wound healing or chronic ulcer is a problem for the patient and the surgeon. Patient undergo a lot of physical, social, psychological and financial trouble. For a surgeon, wound healing is always a challenge and he is always searching for new modalities of wound care. Negative pressure wound therapy is a newer method of wound dressing using sub-atmospheric pressure to promote wound healing. The sub-atmospheric pressure helps to optimize physiology of wound healing by removing bacteria, inflammatory exudates and promote wound healing. It is also known as vacuum-assisted wound closure. Argenta and Moriquez were the first to demonstrate the efficacy of negative pressure wound therapy in their first publication in 1997. VAC therapy is now widely and routinely used in open infected wounds, ulcers, fasciotomies, post-debridement and fractures. Negative pressure wound therapy stabilizes wound environment by reducing the edema, exudate and bacterial load and improving tissue perfusion. It also stimulates granulation and angiogenesis. VAC therapy is a non-pharmacological, non-surgical method for wound modulation and healing. It promotes spontaneous wound healing. It helps wound closure by less reconstructive methods. It decreases morbidity, cost, hospital stay, and enhances patient comfort. The mechanism of action is delivered in two modes, that is continuous mode and intermittent mode. Intermittent mode is a preferred mode. Here the pressure is shut off for 30 to 60 minutes after every 6 to 8 hours. Mode of action. Negative pressure causes tissue hypoxia beneath the foam. Tissue hypoxia releases nitric oxide causing vasodilatation and promotes angiogenesis. This occurs during the pressure off period of VAC therapy. Therefore, intermittent VAC therapy is better than continuous VAC therapy. Increased tissue pressure causes compression of the vessels, increasing the intravascular fluid velocity, which reduces the intravascular hydrostatic pressure. This results in less extravasation of fluid and less edema. The high pressure forces the edema fluid from the injured tissues out to the intravascular space. VAC therapy immobilizes the injured wound area and promotes healing. Negative pressure wound therapy optimizes wound healing by macro deformation or strain, that is a mechanical tissue response, and micro deformation or strain, that is a biological tissue response. Benefits of macro deformation: it draws the edges together, promotes perfusion, reduces edema, and removes the infective material. Benefits of micro deformation: formation of development of granulation tissue through cellular micro deformation, which stimulates metabolic activity and cellular proliferation. The indications of negative pressure wound therapy: diabetic foot ulcers, fasciotomy wounds, infected exudating wounds, bed sores, abdominal or sternotomy wound descents, skin graft fixation, crush or wound or burn wounds. Contraindications are active bleeding ulcers, malignant ulcers, internal fistulas, exposed arteries, nerves and bowel, anastomotic sites, osteomyelitis and blood dyscrasias. Additional uses of negative pressure wound therapy: VAC therapy can be used post skin grafting with pressure of 60 to 75 mmHg. VAC therapy can be used with local antibiotics solution installation also. The system includes a foam or a sponge dressing with a occlusive brace connected with a suction tubing and a vacuum source with a exudate collection to collect the collections. This is the method where the above shown part is the vacuum pump with a tubing connecting with the dressing foam sealed with a film seal, that is an occlusive drape. The method mainly consists of wound preparation by cleaning and debriding to remove the necrotic tissue, followed by dressing placement with a sterile foam which is cut to the size of the wound and placed over the wound bed and sealed with a adhesive drape to create an airtight environment. This is connected with a tubing system, and this in turn is connected with a vacuum source. The pressure applied ranges from -75 to -125, which can be continuous or intermittent. This is negative pressure. This is the setup in our hospital, which we use in the surgery wards. Negative pressure wound therapy during the tenure of 2023 to 2024 in the Department of General Surgery, Unit 5 has conducted this therapy on 300 plus cases, among which non-healing ulcers were 70%, cellulitis cases status fasciotomy were 12%, and wound adhesions cases were 8%, pressure sore cases were 2%, mesh infection cases were 4%, and others like trauma and burns were 4%.
The non-healing ulcer definition is approved international definition taken or local or focal or any criteria definition for that non-healing ulcer incorporation here?
It is based on the appearance of the wound, sir.
I am asking if any criteria there are applied or your own criteria, that's the question.
This criteria applied is international, sir. Time period and the appearance of the wound.
That's what.
Time period more than 6 weeks, it is chronic. And appearance of the wound like a unhealthy or unpale granulation with margins, sclerosed dark margins. These things are classified as chronic non-healing ulcers.
We documented subjectively, documented objectively. That's my question.
And it is clear cut, sir. Evidence. There is acute case or chronic case. We have a clear-cut classification.
Negative pressure wound therapy in India versus abroad in monetary terms. The materials used in India are indigenous foam, polyurethane, polyvinyl, adhesive drape, suction tubing, reusable canister. In abroad, some core items, higher use of pre-sterilized disposable kits are mostly preferred. Cost of the VAC system. This is the total vacuum machine cost.
This is Indian commercial entire system cost from 35,000 to 2 lakhs per system. That is used only for one use.
On rental basis, it is 5,000 to 7,000 per day. In abroad, it ranges from 3,000 to 7,500 dollars. The changing frequency varies from 5 to 7 days in India and up to 7 days in abroad. Maintenance is 1,000 to 3,000 per cycle, and in abroad it is $30 to $100 per cycle. In our institute, we use a polyvinyl sponge which costs 10 rupees, and an IO band, which is an occlusive grade. It ranges from 1,300 to 1,800, depends on the size. And Briles tube, which costs rupees 150, and suction tube set, which costs 150. This all subsides to a cost of average of 600 to 750. These are few illustrative cases. This is on the left side. It is a wound before VAC application. This shows the infective granulation tissue with slough, and after VAC application, it shows the healthy granulation tissue. This was followed by, this is a case of lower limb cellulitis, status post fasciotomy, followed by debridement. Later, split thickness skin grafting was performed. This is a case of abdominal wound dehiscence, status post cesarean section. This is a case of post IV cannulation upper limb cellulitis, status post fasciotomy. The after VAC application image shows the wound shrinking. This is a case of abdominal wound dehiscence, status post exploratory laparotomy. This is the image depicting the administration of negative pressure wound therapy, which was initially of grade 4. Later, after 3 cycles, the wound has shrinked in size to from 15 centimeters diameter to 12 centimeters. Later, after further follow-up, the wound had a diameter of 10 centimeters. This is the video depicting it. This is a case of incisional hernia with mesh infection. Post VAC application, there was a limitation of infection and a wound shrinkage. This is a case of left gluteal abscess, status post debridement, followed by split thickness skin grafting was done. This is a case of carcinoma of breast where modified radical mastectomy was performed, where flap necrosis has occurred, followed by debridement was done, and VAC was applied, which led to shrinkage in the wound size. This is a case of left axillary abscess, which was incised and abscess was drained. Later debridement was done. The after image shows the healthy granulation tissue, followed by split thickness skin grafting was done along with secondary suturing. This is a case of post laparotomy with excision of the ovarian teratoma with multiple anterior abdominal wall sinuses. This is the before and the after image of the after application of the VAC therapy.
One gastroenterologist, he had come across a colonic diverticular burst and abscess. He has done a colonoscopic this procedure. Put sponge and vacuum through the rectum by colonoscopic into that abscess cavity and healed it. That one journal article I have gone through it.
Good evening everyone, myself Dr. Varshini, second year postgraduate from Department of Obstetrics and Gynecology. My moderator Dr. Ratnamam. Case navigating dual risks, advanced maternal age and diabetic ketoacidosis in pre-gestational diabetes. A 40-year elderly, gravid to Paravan living one with 35 weeks, 6 days period of gestation with pre-gestational diabetes mellitus on insulin and tablet metformin 500 mg, brought to hospital with complaints of shortness of breath since 30 minutes on 23rd November 2025. History of presenting illness. Patient was apparently normal 1 day back and present complaint started as shortness of breath, sudden in onset, progressive, aggravated in supine position, relieved in sitting, standing and left lateral position. No paroxysmal nocturnal dyspnea, no complaints of loss of consciousness, no complaints of cough, cold, fever, no complaints of burning micturition, no complaints of chest pain and palpitation. History of present pregnancy. A 40-year-old woman came to obstetrics and gynecology OPD on 25th October 2025 with chief complaints of amenorrhea since 5 months, abdominal distension since 1 month, epigastric pain since 1 month. At the time of initial presentation, she is unaware that she is carrying pregnancy. She got her pregnancy confirmed first time by clinical examination and ultrasound done at Dr. SIMS&RF at 30 weeks, 5 days period of gestation. Antenatal scan was done, single live fetus, cephalic presentation corresponding to 30 weeks, 5 days gestation age. Patient has been advised for antenatal visits. Patient was admitted in hospital on the same day, 25th October 2025 for evaluation of diabetes status. At the time, her fasting blood sugar was 155 mg per dl and postprandial blood sugar was 255 mg per dl, HbA1c of 7.4. At the time, urine ketone bodies were negative. Injection beta-methicillin, 2 doses were given for fetal lung maturity with blood sugar monitoring, GRBS monitoring done 4th hourly. Injection human activated insulin given according to sliding scale. Injection mixed 8 units before breakfast and 6 units before dinner and tablet metformin 500 mg before lunch, advised regarding diabetic diet. Patient was discharged on 29th October 2025 after adequate control. Blood sugar at time of discharge were fasting blood sugar 91 mg per dl and postprandial blood sugar 115 mg per dl. Patient had came for antenatal visit after 2 weeks discharged from hospital. On the day of review, her fasting blood sugar was 90 mg per dl and postprandial blood sugar was 114 mg per dl. Growth scan and fetal Doppler were done, found to be normal. Patient did not come for further antenatal visits. Her marital history, marital life of 25 years, non-consanguineous marriage, husband age was 47 years, farmer by occupation. Previous obstetric history, full-term vaginal delivery at private hospital in Gannavaram, alive boy child, breastfed 1 year, no history of gestational diabetes mellitus or any other comorbidities in previous pregnancy. Her last childbirth 24 years back. Menstrual history, age of menarche 12 years, regular cycles 3 to 4 days, 28 to 30 days cycle, changes 3 pads per day, not associated with clots and dysmenorrhea. Past history, known case of diabetes mellitus since 3 years on tablet metformin 250 mg OD in the morning. Not a known case of hypertension, tuberculosis, thyroid and bronchial asthma. No history of cerebrovascular accident, coronary artery disease, chronic kidney disease and epilepsy. No history of blood transfusions and surgeries. Family history, no family history of diabetes mellitus, hypertension and thyroid. No history of tuberculosis, bronchial asthma, epilepsy, renal disorders in family. No history of cardiovascular disorders, cerebrovascular accidents in family. No history of twin gestations or congenital anomalies in family. Personal history, sleep not disturbed, appetite was good, she takes mixed diet, bowel and bladder movements were regular, no known drug, food environmental allergies. On general examination, patient is conscious, coherent, well oriented to time, place and person, moderately built and nourished. Her height was 166 centimeters, weight of 70 kgs, BMI 25.4 kg per meter square. Pala present, no icterus, cyanosis, clubbing, lymphadenopathy, pedal edema were absent. Vitals at the time of admission, her blood pressure 130 by 70 mm of Hg, pulse rate 120 beats per minute, respiratory rate 20 cycles per minute, temperature afebrile, SpO2 of 99%, on room air. Her GRBS at time of admission 175 mg per dl. Systemic examination, cardiovascular system S1 and S2 were heard, no murmurs, respiratory system bilateral V's present, thyroid no abnormality detected, breast bilateral breast soft. On abdominal examination, inspection, abdomen distended, globular, umbilicus midline and inverted, stria gravidarum and linea nigra were present, no visible scars, sinuses, engorged veins and peristalsis. Palpation, per abdomen, uterus correspond to 36 week, cephalic, relaxed, fetal heart sounds present, 144 beats per minute, no hydramnios. On provisional diagnosis, a 40-year elderly gravida to paravan living on, previous vaginal delivery, 35 weeks, 6 days period of gestation with cephalic presentation, pre-gestational diabetes mellitus on injection mixture and tablet metformin. General medicine referral was taken in view of shortness of breath, wheeze and ECG changes. At the time, ECG sinus tachycardia, vitals of blood pressure 130/70, pulse rate 124 beats per minute, respiratory rate 30 cycles per minute, temperature effibrate 96.4, GRBS 175 mg per dl, cardiovascular system S1 and S2 hertz, no murmurs, respiratory system no added sounds. They advised repeat ECG after 1 hour, 2D echo, complete blood picture, RBS, ABG and review with report. Complete blood picture was done, it is normal, hemoglobin of 11.5 grams. Peripheral smear, impression, normocytic, normochromic blood picture. Viral panel was done, it is non-reactive. Liver functions test was done, normal. ECG, 12-lead ECG showing sinus tachycardia of rate 122 beats per minute. 2D echo was done, tachycardia, no left ventricular regional wall motion abnormalities, normal left and right ventricular function, decreased diastolic complaints, trivial mitral regurgitation, mild TR and PAH, IVC normal and collapsing, no pulmonary embolism, clots or vegetations. Arterial blood gas analysis was done on 23rd 11/25 at admission, pH of 7.4, partial pressure of carbon dioxide 22.3 mmHg, bicarbonate of 15.2, lactate was normal 1.2, anion gap of 19.8. Impression, high anion gap with metabolic acidosis and respiratory alkalosis. Review medicine referral was taken, advised send renal function test, serum bicarbonates, complete urine examination for ketone bodies, repeat ABG, injection human actrapid 644 units subcutaneously, GRBS charting 8th hourly. Complete urine examination was done, protein of 1+ and ketone bodies of 3+ were noted. Renal function tests were done which were normal. Serum bicarbonate of 23.10 milliequivalents per liter. Serum electrolytes were done normal. Arterial blood gas analysis on 24/11/25 10 am, pH of 7.3, partial pressure of oxygen 73.1 mmHg, partial pressure of carbon dioxide 25.9 mmHg, bicarbonate 15.2, anion gap of 15.8 showing
7.4 is a pH, but acidosis, how it goes? This is 7.4, 7.45, and you said metabolic acidosis. It's more of an alkalosis type of.
bicarbonate.
The state, when the pH is disturbed, then it is called acidemia. But when the bicarbonate or carbon dioxide is disturbed, they are called disorders, acidosis, alkalosis. But acidemia, alkalemia are the two words different, which denote a clinical state, and acidosis, alkalosis denote a biochemical abnormality. A biochemical abnormality need not be reflected in terms of acidemic state under the thing. That is a warning signal either to the anesthetist or to the clinician or other two. That is the beauty of nature. Because before they jump into real changes in that of pH, then it becomes a more refractory. At this stage, it becomes a more irreversible component of it. This happens at least 24 to 36 hours, it depending upon the condition at which it travels to acidemia or alkalemia. There are a lot of signals which come us, and our critical care specialist or otherwise everyone will deal with it, not going into acidemia or not going to alkalemia. The moment they go into acidemia and alkalemia with change of pH, there is a lot of problem with the function of the cardiovascular system, both arrhythmias and so on. Agree, sir? Anything to add? Therefore, I clarified acidemia, acidosis, alkalemia, alkalosis.
So no doubt this patient has high anion gap metabolic acidosis.
If
However,
you pronounce acidosis, acidemia, then I will catch.
However, patient is very young with this acidemia. She is hyperventilating. Yeah, and once she becomes fatigued, then every component will come out.
Let them discuss little later.
40-year elderly gravida to paravan living one, previous vaginal delivery with 35 weeks 6 days period of gestation with cephalic presentation with pre-gestational diabetes mellitus on insulin and tablet metformin with atypical metabolic acidosis on a background of controlled diabetes mellitus with pre-eclampsia without severe features. Treatment given, tablet labetalol 200 mg stat was given, IV fluids of 5% dextrose with 6 units actrapid 75 cc per hour and IV fluids of normal saline 20 ml per hour. Case posted for preterm emergency LSCS after correcting dehydration and ketosis in view of pre-gestational diabetes mellitus and preeclampsia without severe features and diabetic ketoacidosis. Primary emergency LSCS was done on 24/11/25 at 1:08 p.m. under spinal anesthesia. Baby presented as vertex and delivered as such an alive girl child of birth weight 3 kg with good Apgar. Baby given mother side, no anomalies were there, no NICU admission. Immediate post of vitals, blood pressure of 130 by 90 mmHg, pulse rate of 90 beats per minute, respiratory rate of 18 cycles per minute, SpO2 of 99% on room air, GRBS 164 mg per dl. Arterial blood gas analysis after LSCS, pH of 7.4, partial pressure 79.3, partial pressure of carbon dioxide 24.8, bicarbonate of 17.8, lactate of 1.2, anion gap of 20 milliequivalents per liter. GRBS monitoring done 4th hourly, no insulin required for 24 hours post-operatively according to sliding scale. From post-operative day 1, injection human actrapid 644 units subcutaneously according to pre and post-meal GRBS. Post-op period was uneventful. On post-op day 8, her fasting blood sugar was 90 and postprandial was 134, kept on tablet metformin 500 and tablet sitagliptin 50 mg twice daily. Patient discharged from hospital. Take-home message, diabetic ketoacidosis, a serious complication develops in approximately 1% of diabetic pregnancies. Euglycemic ketoacidosis.
Take-home message, let moderator discuss and give the opinion. What is the presenting mode, what reason for it, and the other faculty of the
The purpose of presenting this case is, it is a state registered case in our OP and she is 40-year-old. She doesn't know that she is pregnant till 30 weeks of gestation. She has given history of pre-gestational diabetes and she was on metformin. And after diagnosis, after doing ultrasound, we have changed it to Mixtard and metformin. And we have done all the investigations and sent her home, controlling her blood sugar levels, keeping her on metformin and Mixtard, but she was non-compliant. The purpose of presenting this case is women who are not compliant in taking insulin or with intercurrent infections can land up in diabetic ketoacidosis, and that's why she came with history of shortness of breath. And with the help of the other departments, her ketoacidosis was corrected. After correcting her ketoacidosis, cesarean section was done, and she had another dreaded complication, that is pre-eclamptic toxemia, which complicates about 30 to 40% cases of pre-gestation diabetes, and the mother and the baby went home safely. And in such a scenario, with history of pre-gestational diabetes, a pre-pregnancy, pre-conceptional counseling is very important, where you have to control the blood sugars and keep her HbA1c level at 6.5 so that we can prevent the baby anomalies and the later on complications.
In what fashion the diabetic ketoacidosis changes? Here it is a diabetic ketoacidosis or a pregnancy related acid base changes. Comments from that? Yes. Is it a diabetic ketoacidosis or pregnancy-related changes of acid base, because there is a little fall of bicarbonate.
In pregnancy,
Resident question.
in pregnancy, progesterone-related hyperventilation occurs.
Now, Paul is it hyperventilation because she is happily having hypoxia corrected when she is sitting. That's what you have enumerated in your study. When hypoxia in a pregnant lady, that is third trimester, lying down and sitting down, it is coming down. That means milk ventilation is happily going up. That is what is practiced by anesthetists to 30 degrees, 38 degrees in a cephalad portion of flexion. That is what. Therefore, hyperventilation taken off, then why should that blood ABC gas analysis has not come to normal? Therefore, what it tells for the resident, it is the resident job to pick it up. Do you say that it is a ketosis with acidosis? Or do you say it is only ketosis? The acid-base disturbance is related to the term pregnancy. That is the question.
Acidosis with ketosis.
Go back to the things. First one. Yeah. Yes. At this point is important point. Whether there is ketosis or not in this case. Any faculty wants to comment because it is their territory, not mine. Dr. Krishna.
Now, during pregnancy, there are some physiological changes, and mild alkalosis is the common condition as far as pregnancy is concerned. Now, as far as the bicarbonate content is concerned, as a renal compensation of hyperventilation and hypercarbia, more amount of bicarbonate is lost in urine. Bicarbonate levels will be low in pregnancy. Bicarbonate levels, when compared to non-pregnant individuals,
They are low.
They are low.
But they are much more extremely low, make a trigger, or is it really a bicarbonate compensation?
So here, most probably the pH is 7.450, which can be a physiological event as far as pregnancy is concerned.
Therefore, it is not in the pregnancy range because you expect the bicarbonate to fall not more than 2 to 4 millimeters.
So less than 18.
It has fallen about more than 10 milliequivalents.
18 to 22 is a normal pregnancy range as far as bicarbonate is concerned. And the sudden fall in bicarbonate most probably could contribute to the acidotic component in this particular.
Therefore, it's a primary acidosis, not abnormality of pregnancy-related physiological change.
Yeah.
Agree, sir?
Sir has absolutely said right. Pregnancy, you will have some amount of hyperventilation. However, the bicarbonate will not be so low.
It's just 2 or 3.
Exactly.
Anything more, sir, in this which makes you to think that it is a primary abnormality, not pregnancy-related acid-base change?
15 is always
that anion gap.
Anion gap is very high.
Pregnancy, the change in the bicarbonate will be low, little, up to 244. But the anion gap still is likely to preserve. The very fact that the anion gap is changed along with the gross drop of bicarbonate, it is unequivocal evidence of an abnormal acid-base disturbance complicating the pregnancy. That respiratory rate, if you look back, is 20, 30, and she is comfortable on sitting but not lying down. The lungs are dry. But you made someone made wheeze, someone made not. That will come to a little later. Therefore, this is a case a resident should pick up at the ER. That is something abnormal in a diabetic. If non-diabetic, still you have to expect that there is any syncope or something else. Anion gap is high, means any poison or something. Therefore, it should be immediately attended. The first thing to attend in such high anion gap with bicarbonate flow in a diabetic is nothing except fluids of sodium or ringer lactate. Can you give ringer lactate in this? Or sodium chloride? In this case, I am not talking about.
Sir, nowadays, generally in DKA we use the normal saline. However, nowadays people are going for balanced solution because of
balanced ringer.
Yeah, there is something called there are three schools of acid base. One is the Boston school, which talks about pH.
That is called transatlantic, this side and transatlantic,
Yeah.
that side,
The
European.
Dutch school talks about base deficit, base excess.
That is European school.
Yeah, both will not be explained to some extent, where there is something called Stewart's law is applied. Stewart's law says the cations and anions, when there is no balance, it happens. Like, to simplify it, they say sodium minus chloride. So if somebody has sodium minus chloride around 40, means that is a neutral solution, or the serum is neutral.
Whereas in sodium chloride, it is you are giving
Normal
chloride.
saline, when we give normal saline,
Equimolar chloride.
sodium is 154 and chloride is 154.
Equimolar.
So sodium minus chloride becomes 0. Any solution which has a strong ionic difference of 0 is very acidic. Whereas
Then they go for hyperchloremic esters.
hyperchloremic metabolic acidosis. Whereas Ringer has something like 24 SID, strong ionic difference. So it is a better solution. And then when we use
But you give the lactate, which may be or may not be, depending upon the circumstance.
when we give the balanced solutions, where the ions look same like the serum, and strong ionic difference between will be around 40, so the pH will be normal. So people use more of balanced solutions nowadays.
Balanced solution is not available here, very costly affair. But we make it normal saline for the last 30 years. Now one question, sir. In this case of pregnancy complicated by metabolic acidosis of reality of uncontrolled diabetes going in, would you like to advise Ringer lactate as a critical care, because she is going to have a lava, LSCS. After your comments, I will listen to comments from the anesthesia department. And before that, after it is over, then the management comes. Sit down, sir. Now comments, sir.
What's your question, sir?
You like to take up the Ringer lactate as a fluid of hydration, correct? Or a saline, because she is going for a surgery.
To be frank, I have no experience with Ringer lactate and DKS.
I do have, because we have lot of sodium chloride is because the chloride ion excess generating acidosis will be taken care by the normal kidney, except abnormal kidney.
Abnormal definitely will go into acute.
Therefore, the normal kidney function is there. Now, as an anesthetist faculty, we like to prefer a pre-hydration pre-surgical correction of hydration by Ringer lactate or sodium chloride in this case, which is an apparently diabetic ketoacidosis, low sugars. That is a characteristic feature of, as I said, is a diabetes complicated by pregnancy.
Generally, Ringer's lactate will be converted into bicarbonate by the liver.
Yes, wonderful. That's a question. Which comment, sir? So that we'll go lactate in the next case, while priming it, the next case is a totally different, which makes all the difference.
As far as preloading is concerned, better we go for balance of solutions.
That is not available. They have got only normal saline, immediately Ringer lactate with little difficulty.
But at the end of the day, sir, what patient needs is hydration.
And one more thing.
But we cannot give hydration normal water. Sir?
Unless diabetic ketoacidosis is corrected, we cannot go for surgery also. Unless DK is corrected, we will not take up for surgery also.
No, I do not agree.
2 to 3 hours we have.
No. DK can be corrected in hours and minutes.
Yes, sir.
And the surgery is a prompt thing of different emergency. We will wait for the correction, and the physician job is to correct it as fast as possible. Therefore, that statement in an institute doesn't hold. Now come to the answers, madam. I don't believe it. DK is being corrected. Before correction of DKA, you would like to have a normal saline or Ringer. As he said, his ideal solution is isolate. That means
Plasmalate is ideal.
I prefer normal saline for the simple reason. kidney function is normal. Two, in a pregnancy, the liver is also at abnormality. How much lactate it can be metabolized by the pregnant liver? As a person not pregnant is a question. Because they were going to, because they already in decay. Why? The lactate has lot of amount of abnormalities with reference to anesthetic vascular compromise. That means reactivity of needed in hypotension for vasoactive substances and otherwise is a question mark when you give it too much of lactate. Until the liver is known that it is clearing the lactate to glucose by what much effective or what much? No, that's all. The preeclampsia is a low volume status and already had already a pregnancy is high volume state. Unfortunately, there is a metabolic dehydration and a preeclampsia. And then you are giving a beta blocker, levotalol, pre. Then volume estimation and pressure management by the anesthetist. This is a tough task of working on a tightrope. Therefore, I will prefer volume efficiency by sodium chloride. If the kidney takes chloride, lactate doesn't matter because no lactate. And therefore, you would correct it with a good amount of hydration. We'll give you whatever time we give, we correct and bring you the patient with a non-ketotic state. That is the responsibility of the things because we cannot postpone a surgery for this purpose. In institute.
Sir, in the context of hypertension in this pregnancy, in the context of hypertension in this particular pregnancy, can we give IV fluids at a faster rate? Usually we.
A wonderful question.
Usually we say we need to restrict fluids.
That's what they have done echocardiography. Echocardiography was done.
Echo was normal.
No, I am not interested in normal echo. I am interested in the IVC of echo. If IVC is collapsed or dilated, if it is collapsed, and you will monitor it as our critical care specialist.
Well, sir, IVC alone may not.
But in pregnancy, it is very difficult to monitor IVC.
Very difficult. The other things that we have to go like pulse pressure variation is one way. The other is stroke volume variation where we use the cardiac output monitoring. These can be.
Therefore, as far as this case is concerned, your pertinent question cannot be answered. IVC is the normal thing at ICU, but IVC cannot be well visualized in a lab as well as in anesthesia. And therefore, you need to stay continuous monitoring of LV activity and log. This is already in pregnancy very high. And levotalol.
There is another way.
You said cardiac output monitoring. This we used to do 40 years back with Swan-Ganz catheter, thermodilution, all those things. Once of the echocardiogram, especially with the Doppler facility, that has become little less redundant over it. Only a few patients where they have a complex multi-system anomalies, sometimes you do. Otherwise, normally nowadays we don't do Swan-Ganz catheter and cardiac output measurements also.
Since you brought up, there is another way also, like we do the cardiac output measurement by velocity time interval.
That output, echo we can make it, that's not the question. But no, we measure it. But
that is easier non-invasive component of measuring.
But it's not it will not give a correct idea.
As he requires it, as the anesthetist requires.
Okay.
This is at the table. Because the preeclampsia is a low volume and low concentrated state, suddenly it may go into post anesthesia. It is severe it may not be it. And then catastrophic complication to the mother, not to the fetus. Nothing happens. Now, anything you like to add yourself? Then we'll go to the little component factor. What is the utility of lactate with reference to clinical medicine? Here the lactate which you measure is L-lactate. What our critical care specialist studies D-lactate in intestinal ischemia.
Yes.
What is its role from the gut? We will have a interaction in the next case. And any questions further in this case? This is case. What? As far as pregnancy is concerned, the long-acting animal insulins Animal insulins have gone to treat animal diabetes, no more human diabetes. In 21st century. And all human insulin. Human insulins are no contraindication, mixed otherwise. But to gauge the quantum of insulin, you go with a short-acting insulin or a short-acting regular. After once you establish the quantum, you titrate to the mixed variant, and before labor or after surgery, you come back. Even not necessary to change, and you have to rapid. Therefore, and lastly, human insulins, analog insulins are approved. Analogs that human insulins like, but they can have some effects, biosimilars, like tertogenic postman. That is well established. All analogs of regular insulins can be used in pregnancy without hesitation, any part, except long-acting analogs. Few are accepted internationally, one or two are not accepted. Very long-acting. That's our last case.
Hello everyone. Today my presenting case is catastrophic triviality from the Department of General Medicine. Chief complaints: a 45-year-old woman presented with a alleged history of trauma, self-harm while going on escalator. Complaint and restriction. Yes.
The slides were very good. Full, you can see it better.
Pain and restriction of movements of right elbow and right wrist and presented to Dr. SIMS&RF. No history of loss of consciousness, vomiting and headache. No history of chest pain, shortness of breath and palpitations.
Where is Akshi? Please. Hello. Where is Akshi? What is this? We have two mics.
No history of pain, abdomen and loose stools. No history of cough with expectoration. Past history: patient is a known case of type 2 diabetes mellitus since 13 years on tablimipirate plus metformin. 12th hourly with known case of hypertension since 13 years on metoprolol 50 mg 24th hourly. The known hypothyroidism since 13 years on tabthyronone 100 mcg 24th hourly. The known case of CLD with portal hypertension with cirrhosis since 5 years. On tab lacilactone 12th hourly and tab carvedilol 3.15 mg 12th hourly and tab rifaximin 550 mg 12th hourly with tab udilium 450 mg 12th hourly. Person history takes mixed diet, normal bowel and bladder habits with normal sleep and appetite, not a smoker and alcoholic. Family history: mother is diabetic at 40 years of age. Menstrual history: the regular cycles, no menorrhagia, clots or white discharge. General condition on examination: patient is conscious, coherent, oriented to time, place and person, well built and nourished. Pallor is present with pedal edema, pitting type, slow filling and bilateral. Whites at the time of presentation: patient has BP of 138 mmHg, pulse at 92, respiratory rate 14 and saturation of 98 on room air. The GRPS of 549, FF rate. Systemic examination: respiratory system was normal. G8 examination: abdomen is distended with spleen palpable 2 cm above the umbilicus. Cardiovascular system examination was normal and CNS examination was normal. Provisional diagnosis was traumatic fracture to left distal humerus and left distal radius bone. The known case of type 2 DM, hypertension, cirrhosis, chronic liver disease with portal hypertension and hypothyroidism. CPP at the time of presentation shows SPB of 9.3, elevated ESR with thrombocytopenia. Total LFT is deranged with total bilirubin of 2.3 and direct 1.3 and indirect 1. ALP elevated with 157. Serum electrolyte showing sodium of 126 with normal RFT. CU showing WBC of 94 and bacteria of 20, which indicates UTI. Coagulation profile was normal and HbA1c was 10.8 with RBS was 549, TSH of 5.19. This is ECG. It shows normal sinus rhythm.
This is lateral radiograph of left forearm showing comminuted displaced fracture at the distal end of humerus, possibly supracondylar fracture of humerus, along with the comminuted fracture at the distal end of radius with dorsal displacement, possibly collis fracture. There is slab noted, and all the rest of the bones are normal.
General medicine referral was taken in view of high blood sugars. At the time of examination, blood ketones was 2.1, advised IV fluids, actrapid 6 units, IV stat followed by 12 units subcut and followed by IV actrapid 6 units per hour infusion, and to send CU, HbA1c and APG.
At this point, I would like to comment for the audience saying, it is always preferable to see the blood ketones rather than urinary ketones, because blood ketones only available. We have got in ICU also blood ketones apparatus and all these things. Why ketones estimated in the blood are beta hydroxybutyrate, whereas the ketone in the urine acetone. They don't reflect one to the other. Beta hydroxybutyrate is the molecule for determination and follow-up and treatment evaluation of ketosis. Therefore, our institute is endowed with to take blood ketones. Go ahead.
The time the calculated serum osmolarity was 298. AVG at the time of admission was pH of 7.4, PCO to 18.4, bicarbonate of 9.3 and lactate of 2.9. On SpO2 of 99 room air and BP of 138. Treatment from day 1 to day 3, no IV fluids was given to the patient. Tab metoprolol 24th hourly, tab UDD 450 mg 12th hourly, tab cardivas 3.125 mg 12th hourly, rifaximin 550 mg 12th hourly, Sirozam 12th hourly, and Tramadol 12th hourly with Pantop 40 mg 24th hourly, and Actrapid according to GRBs of T8. Patient was in orthopedic ward from day of admission to day 3. On day 4, patient was shifted from orthopedic ward to MIC in view of altered sensorium, agitation and tachypnea. Patient is conscious, irritable, not obeying commands. On presentation, patient vitals was BB of 100/60 and pulse rate was 119 beats per minute with respiratory rate of 30 cpm and saturation was 94 on room air, normal temperature. Time of at the presentation at the ICU, examination was normal.
This is a frontal chest radiograph. This is a mid-inspiratory film. Patient is in mild rotation. Cardiac shadow appears to be enlarged. It's apparent cardiomegaly. There is a prominence of bronchovascular markings noted in bilateral lung fields. Both terms of diaphragm well outlined. Both CP angles are free.
In view of altered sensorium, patient was advised for CT treatment.
So CT axial images of brain showing diffuse cerebral atrophy and also ill-defined hypodensity is noted in bilateral periventricular and deep pigmented regions suggest for small vessel ischemia.
Patient was evaluated in ICG for the next 3 consecutive days for the sudden onset of SOP and altered sensorium.
You like to comment at this point with this ABGs, madam? Because in the last case it is a diabetic ketoacidosis. This is also hyperosmolar ketosis, predominantly hyperosmolar state with little ketosis. And became diabetic post-fracture. But come in. In diabetic acidosis, why should lactate elevate as our critical care just not told, unless there is hypotension. But as blood pressure is normal, I think so. Therefore, there is no perfusion defect. And the lactate is gradually mounting up to double, 5.4, 7 point and then at the leg of treatment. That is one of the important clues that the underlying liver disease is responsible for hyperlactatemia.
Due to CLD component, the lactate.
Therefore, any lactate persistence increase with the normal blood pressure, but acidosis, think that there is underlying liver disease in addition to it, which is a nightmare for anesthesia. That should be taken with cognizance. That hypoxia cannot exploit totally the hypoxic encephalopathy, but the patient is drowsy and altered sensory. Next.
The web CBP shows foreign HB with foreign platelet at day 5 and gradual increase of platelet count. LFT day-wise evaluation showed altered LFT from 2.3 to 2.9 with direct pattern.
Low albumin.
With low albumin. Day-wise electrolytes, sodium from 126 to 131 and RFT was normal.
That hyponatremia is a secondary aldosteronic hyponatremia of third space expansion of cirrhosis.
Compared to day 4 to day 6, chest X-ray finding shows prominent bronchovascular markings and also pulmonary vasculature appears prominent and few alveolar opacities scattered throughout the bilateral lung fields. Rest of the findings remain same.
Today echo was normal. In fundoscopy was done which shows both eyes normal fundus with no signs of raised ICP and no retinal changes, suggesting of fat embolism syndrome. Ultrasound abdomen pelvis was done which showed altered hepatic parenchymal echo pattern with prominent portal vein measuring 15 mm and splenomegaly with enlarged and tortuous splenic vein. Bilateral grade 1 renal parenchymal changes, tiny left renal canicula and mild ascites. Treatment from day 4 to day 6 during ICU stay was with the IV fluids and the injection pet pads, injection mixture 35 units 20. Initially it was actrapid, then converted to mixture, injection pantof, tab rifaximin and tab butylume, tab thyronone, tab metoprolol, oxygen support, for which patient initially received NIV ventilation, later nasal prongs. Patient was hemodynamically stabilized and shifted and transferred to Department of Orthopedics for surgery. Patient was suspected for fat embolism syndrome. We used Gold's criteria to diagnosis. There should be 1 or 2 major criteria with 4 minor criteria to diagnose a suspected fat embolism syndrome. Major criteria includes petechial rash or respiratory insufficiency, which PaO2 of less than 60 mm, Hg, FaO2 of 0.4, tachypnea, dyspnea, and hypoxia syndromes, and cerebral involvement. We can see disproportionate to hypoxia. Patient have confusion, agitation, seizures, and coma. Minor criteria includes out of these 4 has to be present to diagnose it. Tachycardia, a fever, retinal changes, which are evaluated through fundoscopy of fat globules or hemorrhages or papillary edema. The jaundice, renal dysfunction like oliguria or anuria, anemia, thrombocytopenia, high ESR, and fat microglobulin, fat globules in the urine or sputum. Total score of 2 major and 5 minor is present in our patient. So final diagnosis of fat embolism syndrome was diagnosed. Final diagnosis comminuted right distal humerus fracture with right distal iris fracture. Hyperglycemic hypoglycemia state with mild ketosis, which is recovered. Fat embolization syndrome of grade 2 in UTI recovered. The known case of type 2 DM, hypertension, chronic liver disease, total hypertension of call grading 2 and hypothyroidism. Discussion. Fat embolism syndrome is diagnosed clinically using Gold's
They
criteria.
had mild fat embolization on a background of a decompensated liver disease, which reduced and a complicated by hyperosmolar state with ketosis and secondary lactic acidosis. Because of ketosis, the lactate is not being metabolized by the kidney of stage 3 or otherwise, because advanced CLD, chronic liver disease with pot liver. Therefore, it took about 3 to 4 days for the lactate to clear and the rest of the things. Can it be a simple hyperosmolar state, but is not comatose, but she is altered sensory? Non-ketotic, but ketosis are present in blood 1.2, and there is a bicarbonate relative fall. Yeah, wonderful. Hepatic encephalopathy, can it be? That's the question. Hepatic encephalopathy is a decrease in ventilation with altered sensorium to coma and not coming out. But here they agitated, hypoxic, and then after that it's come out.
Then too, in fat embolism.
Therefore, 2 things contention is hyperosmolar state, hepatic encephalopathy. We have corrected the acidosis, we have corrected the cause of hyperglycemia, nothing else was done. And she continued the anti-treatment and came up to court.
That is the fat embolism discouraged.
Yeah. That's a question. But fat embolism, longer, but the component is where the bone marrow. That is a divergent and a convergent component. In the long bones, it is a convergent, it is divergent. But anything, I am not talking about classical flat embolism, because there is no coagulopathy, nor skin manifestation, nor retina. That is responsible for the precipitation of hypoxia acutely with 560. Normally, hyperosmolar coma, the last thing to be developing is pulmonary component. First thing is dehydration and cerebrovascular and convulsions and so on. Go ahead. Over. There is a little amount of fluffy densities in the interstitium of the lung. Whereas in hyperosmolar coma, the lung waste part of the blood.
Fat embolism usually occurs after 24 to 78 hours of long bone fracture. Initially, respiratory symptoms appears first, then CNS, followed by petechial rash. Prognosis and complication: many patients recover fully with supportive care. Neurological deficiencies may be reversible. Severe and fulminant cases can progress to ARDS, multi-organ failure and death. Long-term sequelae can occur but are variable. Mortality decreases with modern critical care. Usually, treatment is usually supportive.
Thank you.
Thank you.
Any questions? This case here we represented again and diabetic ketoacidosis persistent lactemia, which is due to underlying chronic liver disease. Thus, a pregnancy liver can handle but not more. That's why lactate